Hi everybody. I've cut up the information this week so we can have less slides and maybe shorter videos, and then you can kind of go back and forth between the smaller videos for content that you need. So we're going to do problems of ventilation today. Let's talk about influenza. Now, influenza, you're all being hammered about influenza. You've got to get your flu shot. But the problem isn't so much the infection that you guys would get. Of course, that would be terrible, but it's also how you can transmit it to those in the hospital who are clearly a very vulnerable population and are already sick with decreased immune systems, and they could even get sicker. So influenza is highly contagious, transmitted from animals to humans, and it's communicable between humans via droplet contact and inhalation of aerosolized particles. So this person might be on, what do you think? How about respiratory isolation? So what are the symptoms for all of you that have had the flu before? You're going to immediately know what I'm talking about. For those of you that are lucky enough to have never had the flu, think of an overall feeling of malaise, pain in the muscles, sometimes headache. It could also mimic some cold symptoms where you've got a cough, a sore throat, runny nose. But in general, the thing that separates the cold from the flu really has the body aches and often accompanied by fever and chills. The cold, you've just got that stuffy head feeling, congestion, cough, etc. I'm not covering the upper respiratory area. As you've seen some of the areas in the book, we're doing what you will be seeing, what you might be seeing in the hospital, and influenza you might be seeing in the hospital. But generally, persons are not hospitalized for a cold. That would be outpatient. So what are the complications? The complications would be dyspnea and diffuse crackles with which can cause what? Causes pneumonia. Pneumonia, however, in the flu really would be more viral or immune acquired. I'll talk a little bit more about pneumonia in a minute. But some of the complications, like for example, in pregnant women really do absolutely need the flu vaccine. A third of the women that get the flu will end up in the hospital with pneumonia, and a third of those will end up in the ICU, possibly with real complications. So how do you diagnose the flu? A culture is done, often a nasopharyngeal or throat swab. Those are available at Ready Clinic, your doctor's office, or your nurse practitioner's office. Viral cultures. Now serology, what's serology? Like a complete blood count, right? So the serology, that would show the elevated white counts, etc., and can differentiate between viral, bacteria. So if it's bacterial, then it's probably not the flu, because the flu is virus. So prevention, that is the best treatment. So the treatment starts in about September. The prevention, vaccinate all people older than 6 months, especially those at high risk. There are a variety of different types of vaccines. There's the nasal or the IM. That's the extent of the variety. The nasal sprays are kind of, they're not as prevalent anymore as the IM. So who's high priority groups? How about those with chronic illnesses? Those with diabetes? Pregnant women are considered high priority groups. So what's the treatment? It's a viral, right? So do antibiotics work for this? Nope. Antibiotics do not work for this. it's viral. So in some cases, antiviral medications can work generally within the first 24 to 48 hours of symptoms. But it's really symptom relief, rest, hydration, supportive therapy. Now, does getting the vaccine mean you won't get the flu? Nope, it doesn't. Because the flu vaccine is a statistical prediction from the years before of the type of viral strain. So, for example, to pull a example out of the hat, flu vaccine type A through G is what the vaccine is for, because that's predicted the strains from previous years. What if you get strain M? Well, then you're going to get the flu. But often getting the immunization can lessen some of the symptoms of the flu as well. Okay, so that's just a brief talk about influenza. So lower respiratory tract infections. Let's talk about acute bronchitis. So acute bronchitis, most common clinical manifestation. So, well, before that, what's bronchitis? Itis, inflammation of the bronchioles, right? Acute, it has just happened. What's significant about this is it usually occurs after a viral upper respiratory infection. So it occurs after a viral upper respiratory infection. So does that mean they get antibiotics? No, it's viral, right? So the clinical manifestations, so if you have inflammation of the bronchioles, what do the bronchioles do? Okay, they allow air to pass through. So if air can't get through, what are your clinical manifestations? You're going to cough. You're going to have more mucus. You don't feel well because you're not perfusing air as well as you should have, right? And your lungs are having to work harder, so you might have some chest pain or difficulty breathing. The fever is just from the body, the virus. Now, the difficulty is that it can last for a few weeks. It's an inflammatory process, and it takes time for it to go away. It is evident at night. The cough is the most frequent at night, so their partner or spouse might complain that the patient's keeping them up all night because they've got a consistent cough. And it's kind of like a spasmodic cough, or when somebody's speaking, or too much, or too long, or taking big deep breaths, or laughing. That can cause a spasmodic cough. Diagnosis, assessment of breath sounds, your history. Did you just have a cold? You might hear some consolidation in the lungs. Now, the chest x-ray, what the chest x-ray is going to do is it's going to determine that there's no pneumonia. So remember, when we're talking about diagnosis, we want to rule out the significant stuff, right? So a chest x-ray would tell us if there was pneumonia present, which, depending on what kind, maybe needs some more vigorous treatment. So acute bronchitis is usually self-limiting. This is usually outpatient, okay? But I do want to talk about it because it is a side, a complication of a upper respiratory infection. So usually what needs to happen are cough suppressants. So the lungs can rest. Bronchodilators, also similar to what maybe asthmatic patients would be. In fact, a lot of the clinical manifestations, that frequent cough or that dyspnea, that difficulty breathing, and some of the treatment are the same in asthma. But bronchitis, self-limiting, it will go away. Corticosteroids for those with a lot of wheezing. Complementary alternative methods, what could some of those be? How about some essential oils? Eucalyptus, chamomile for relaxation, humidifier, vapor rub, those things that can open up the airway. And then, of course, antivirals, if caused by virus, which it generally is. Antivirals it's usually gone before one needs to go through that step. Okay, so before I get to pneumonia, I'm going to talk to you about pertussis. Pertussis is you've all been immunized against pertussis. It is part of the Tdap, the tetanus vaccine. So it's tetanus, diphtheria, and pertussis. When you're a baby, it's called DTaP because it has more of the diphtheria component in it. But now, so it used to be where patients were just getting a tetanus, but now it includes the pertussis because remember how I talked about last week, vaccines change over what they do in society and communities, and now we're finding pertussis is being in the adults now. It used to be just a kid infection, but now we're finding it more in the adult population. So it's highly contagious, caused by the Bordetella pertussis. So one might have like cold symptoms, mild upper respiratory, low-grade fever, non-productive cough. But then the second stage is this paroxysms of cough, this spasmodic cough, and it has like a whooping sound. So listen to this. Hold on. So did you hear that sound? That's from the spasms and the that infection that causes the inflammation. So this person absolutely needs antibiotics, usually macrolides. Macrolides such as what? What's a macrolide? How about azithromycin or erythromycin, clarithromycin? Okay, now briefly, pneumonia. So pneumonia, there's a few different types of a pneumonia. So it's an infection of the lung. So bronchitis can go into pneumonia, but bronchitis is upper area. Pneumonia can be in any part of the lung. So it's seen on X-ray. Types of pneumonia, community-acquired pneumonia. So that's like out in the grocery store, out in the field, just people normally walking around. This is the healthy individual that happens to get pneumonia, either bronchitis that goes south, but this is a person who got it because of whatever other factor. Medical care associated pneumonia. So what's an example of this? So this is someone that is hospital associated, at least 48 hours after the hospitalization. Maybe someone that's been on a ventilator or long-term care. Now, aspiration pneumonia, what's that? We've talked about it a lot. Who's at risk? Yes, seizure, stroke, Alzheimer's disease, Parkinson's, those with muscular problems. Okay, so what are the clinical manifestations of pneumonia? These might sound familiar, okay? Difference between bronchitis and pneumonia. Bronchitis is clear mucus. Pneumonia may be green, yellow, rust-colored, or bloody from the inflammation and from the infection or from the constant coughing. Some of the varices might pop, the capillaries in your esophageal area. Pleuritic chest pain. So it's going to hurt specifically where the infection is. Tachypnea, dyspnea, fever. How do you diagnose this? Like I said, the chest x-ray. The gram stain of the sputum, someone spitting up their sputum and sending that for culture. Pulse oximetry or ABGs, a person with bronchitis still may have perfusion, 100% perfusion, 100% oxygen saturation with perfusion. This person is struggling. Both of their lungs are not working correctly. Routine blood chemistries, blood cultures, you can all reflect on what those will check. So complications of this, lung abscess, bacteremia, acute respiratory failure, pneumothorax, so everything that can go wrong when your lungs continue to fail. What's treatment? Well, if it's bacterial, antibiotic therapy. Otherwise, symptomatic treatment. All, I mean, of course, symptomatic treatment as well, but very much the antibiotics if an antibiotic is needed. And of course, it's dependent on what type of pneumonia. So prevention, decreased smoking, proper nutrition, adequate rest, and for those that really need to, they might be needing vaccines. And it is recommended for those that are greater than 65 years old. Again, people that are over 65 have other comorbidities. Thank you.